Okay,
I don't
got it.
think there's a couple. Yeah, we can just, if there's late joiners, they will
Yeah.
just miss the beginning, I guess.
Yeah. Yeah. Let's roll.
Okay. All right. Start on time, darn it. Okay, so let me, I'm a little bit new to all this technology, so bear with me if there's a moment in between sharing screens. Nick was rock star last week with his audio visuals. He and I practiced a couple times yesterday. So today's class is on thoracic outlet syndrome, and hopefully you've all had the chance to, at least learn about it when you're in massage school, for those of you that are newer, and even maybe deal with some clients that have presented with this issue. I am going to just show you a little, let's see, I'm going to try and click on a screen to share to show, so that's way too far in advance. Okay, because I made a nice slideshow. Hang on here. Gotta make it full screen. Okay, can people see that? Yes. Okay, so this is the outline of what we're going to be talking about today. Yeah, interestingly similar to Nick's experience with carpal tunnel last week, I have my own history with thoracic outlet syndrome. So I'm going to share a little bit about that first. Then we're going to look at the causes, what can cause this issue, signs and symptoms, do a really good anatomy review. And then there are some muscle testing techniques that you can use with clients. I'm a little mixed on that, but we'll talk about that. Approach, massage techniques, home care, and Q&A. So I think it'll be enough to fill an hour. Okay, hang on one second. I'm going to just get out of the screen. Okay, so I want to tell you a little bit about my history. Anyone that's worked with me has probably seen me icing my neck and doing perpetual like stretches. I'm always doing this and kind of moving my shoulder and complaining about nerve pain. And sadly, I have actually, I've probably had thoracic outlet syndrome for most of my massaging career. It started pretty early on, but I actually think that I had some precursors earlier in my, I know that I did earlier in my life to lead me to a position that was vulnerable to achieving that when I started doing a lot of hands-on massage therapy. So my precursors were, I grew up a competitive swimmer and I swam through college, and I very distinctly remember from a really early age having the coaches work with us on just making our shoulders, like, I can't even do it anymore, but so mobile. We would do so many stretches to almost create hypermobility. And for instance, with, yeah, there's Amy. For instance, with the forward strokes to pull the water, I remember they would actually have us jutting our shoulders so far forward on purpose because you wanted to reach out as far as possible to grab the water and be able to pull it back in. And, you know, flexibility is fine unless it's not supported with strength. So I feel like my shoulders were like hypermobile and definitely already overused from a really young age. After I was done with like college swimming, I waited tables for a few years before I went to massage therapy school. And because I was so used to kind of having my shoulders jacked in that front position, I would hold the waitress tray like this, like literally, I don't know if you could see that, but my shoulder was super, super forward. So I was just constantly at position, especially on the right side. But I never thought anything of it. You know, I was 20 years old, had no pain, felt really strong. And then when I started massaging, I actually started a very, very full schedule because I started at a really busy spa. So I didn't have that nice slow ramp up where you could kind of build your strength and build your clientele slowly. I was happy to do it and happy to have a strong paycheck from early on, but I know that I was trying really hard to do high volume and deep tissue work. And I distinctly remember at one point when I was working on a client who I could not possibly go deep enough for her. Like, she just kept asking for more pressure, and I was just trying so hard. And I'm sure that I was using a lot of these muscles inappropriately in an imbalanced way, and was probably even straining with my neck to try to get more power from some place. And it wasn't that moment that I felt like I instantly had thoracic outlet syndrome, but I know just thinking back and putting together my history, I'm like, wow, that was that massage was probably a little too intense, or I was trying to do it too intensely. And then, probably a few weeks later, I was just doing regular effleurage on the back of a client, and I very distinctly remember like, that's weird. My pinky's numb. And that's not a good feeling to have, especially when you're laying your hands on people all day long. It was just this very bizarre, like, we all know what numbness and tingling feels like, but when you have to roll that onto people all day long, it was distracting and confusing to me. Even though I had heard about thoracic outlet, I still didn't think anything of it. Of course, kept working, just continued on, didn't think anything. And then it kept getting worse and worse and worse. I think I also probably had a rotator cuff tear at some point. So when it was really bad, it was very, very bad. It was, trigger points all in my ribs, my scapula, shoulder. I couldn't even when I was even just hanging out, not doing massage, like going to dinner somewhere, my family was like, "Are you okay?" Because I was like wrenching my neck like this and just trying desperately to get away from the pain. It was that bad. So I don't recommend that, but just to give a personal example of really how things can progress, and how if you have a client that comes to you in whatever stage along the way, nerve pain it's really interesting, and I wouldn't even call myself fully recovered, and that's why I still ice now, but I am like 95% better than that worst possible place, and that's good. But I've done it with self-therapy, massage, a lot of stretching, and a lot of PT, and a lot of self-correction for alignment, because you can't just instantly change your posture. It takes a lot of time. And I guess the one kind of overriding factor I would like everyone to remember when thinking about thoracic outlet and any nerve compression is nerves take forever. They take forever to heal. They take forever to recover. If the muscle is better, sometimes the nerve is still unhappy because it's been so inflamed and so irritated that it can be frustrating for the client, and it can be frustrating for the therapist, but you're still doing good work and helping that person. But I like to tell my clients that when dealing with any nerve issue, not just from my personal experience, but even from reading medical pathology books, they all say that about nerve compression issues. It's just a strange conundrum. I think that nerve tissue takes a long time to regenerate and to heal. It's very different from muscle tissue. So
I was saying that. Can you describe, like, kind of in detail the symptoms that thoracic outlet made you feel?
Yeah, and I've got a whole awesome page for just general thoracic outlet, but for me, it was like just stabbing trigger points in my rib cage. I remember once when I was driving, and of course your arms are forward when you're driving, I literally thought to myself, I think I must have lung cancer. Because I thought nothing else in the world could possibly be this painful. I just thought cancer, bad. So that was an interesting lesson too. Like, you think of trigger points as just being, okay, these little pain spots here and there. This was like being stabbed with a knife. But that's also because I think I had rotator cuff stuff happening. For the thoracic outlet, I tend to get very inflamed on this side of my neck. I can, when I was exercising, for instance, we'll talk about the vascular stuff that happens along with the nerve. When your pulse rate is up, it can actually also pinch down the brachial plexus. So that wasn't fun. You're trying to exercise and be mobile. And then I would just feel this kind of like, it was just nagging, like an irritation on the nerve. So yeah, and then the numbness in the pinky, numbness when you wake up at night. So, but yeah, that's what I felt, which was, yeah. So let me I want to click back to the next page. Sorry, bear with me here. Oh, phone call. Okay, so
I'm going to bow out.
Okay. All right, so here's some causes. So we're going to go into a little bit of the background for thoracic outlet syndrome. I'll try and not just read this. Can everyone see this okay on their screens?
Yes.
Okay. So the interesting thing about thoracic outlet is that it is the compression of the nerves or blood vessels in that section of the body, but it can be caused not just from muscles. It can be the vascular bundle, and it can also be caused by your your cervical vertebrae. Another interesting fact about it is anatomical defects. It's kind of weird that they phrased it anatomical defects, but if you inherit something like an extra rib, believe it or not, this first rib is really, really high up here, but you can actually, some people have an extra one. So when we look at the anatomical diagram later, you'll really see that there's not a lot of room in there to begin with. So it makes perfect sense that that would cause a pinch. And I actually worked with a massage therapist at that first spa I started out at, and she had that extra rib removed at one point in her childhood because they knew it was not supposed to be there. And she still had thoracic outlet issues because she had a scar tissue from the surgery. So I thought that was kind of fascinating that sometimes people actually get that removed. Or apparently you can also get a tight fibrous band connecting your spine to your rib. Haven't seen any good diagrams showing that. Of course, we know poor posture is the cause for lots of different issues. We're also forward head postured in this culture. Computer posture, driving, for us doing massage therapy, manual labor. Interesting factoid, if you imagine using crutches, you got these crutches shoved into the axillary area, you're probably also doing this while you're holding yourself up. People aren't used to that position. So if you have a client that's coming in with, say, a broken foot, you never know, they might end up with thoracic outlet in addition to the broken foot. Next is trauma, could be another cause. Of course, if you have a MVA, car accident, whiplash, I actually think I had a couple minor ones when I was younger, very minor, but still, we all know that you don't need to have a 60-mile-an-hour crash to have an issue later in life, and these things do come back later in life. So I always do a very, very thorough intake whenever anyone presents any issue with the neck, because sometimes people don't think that a 20 years ago car accident could be the cause of what they're dealing with now, but it really does set you, unfortunately, into a, kind of not a spiral, but a continuation of that can be early degradation or misalignment. Okay, that says that right here. Onset of symptoms can often be delayed. Next cause is repetitive activity. And yeah, we all know that. Computer, mouse hand, massage therapy, anything where you're doing especially fine movements over and over. People tend to engage the muscles in ways that we're not really meant to be. We're kind of meant to be hunters and gatherers and big dynamic movements and running and, getting our animals to kill to bring to the family or something. Like, humans weren't made to be sitting at a computer doing like fine repetitive movements and being stressed on top of that. So like, imagine all these neck muscles and these pec muscles, kind of a fight or flight, but yet we can't fight or flight. We're just sitting in one position. So yep, they talk to right down here, athletes such as baseball pitchers. Imagine that pitcher's arm. Or even the baseball types that are out in the field, they're kind of hunched over, just holding that position, waiting to, catch a ball. And then swimmers can also develop thoracic outlet from just years and years of repetitive movements. Another cause could be pressure on your joints. So unfortunately, obesity will put stress on your whole body. Or if you're not obese, but you're carrying an obese bag, you can be putting a lot of strain on the shoulder joint. Pregnancy, and they say it's because your joints with the elastin that adds the extra laxity in your joints. And I think too, maybe with the swelling, can just cause a little bit more compression in that area. Any questions or extra comments on causes? No? Okay. Sorry, I can't hear. Can everybody hear me? Okay.
Yeah, I've got everybody muted. I think you can unmute yourself, right?
Yeah.
Yeah. Okay. Good.
You can also just hit your space bar if you just want to say something.
Oh,
Really?
Okay.
Yeah, you hit the space bar, hold it while you're talking.
Cool. Yeah, I remember reading that trick once, the spacebar trick. Okay, so we'll move on then. Let's see, outline, we did personal background, causes. Now we'll move on to signs and symptoms. We got into this a little bit. And after this, next slide, I inserted an extra one where I'm going to talk about a little bit of the differences between carpal tunnel and thoracic outlet. And I think this is, Nick said it best, but it's a really great follow-up class to carpal tunnel, which we learned about last week. First of all, because it works its way up the arm a little bit, but secondly, because they're often presenting very similar symptoms, but they have important differences. So let's just focus on thoracic outlet for now. Signs and symptoms: numbness in the anterior forearm, and specifically numbness in the last two fingers, the ring finger and the pinky. Very, very important. Please remember that. We talked about it already, but you can kind of feel like you're waking up in the middle of the night with your arm being dead, or anybody ever like wake up and it's just like you can't even, your arm is like plunking off the bed because like you can't even function anymore. That's how dead it is. Progressed cases, yes, it can end up moving more into the forearm, arm and neck, back, and of course pain and tenderness in the shoulder girdle, neck and hand, and that's especially when you start compensating. So and if you've got a tight pec minor and scalenes, you're going to have a lot of tenderness there because those muscles aren't really meant to be doing the work that they're doing to get that tight to pinch down the brachial plexus. You can also end up with some edema in the hand because if the vascular bundle is being pinched, you're not going to get the same circulation. So one thing that I read that was really interesting was the person said to take a photograph of the hands, not just to look at the hands, because something about the photograph, he was able to ascertain edema a lot better than just seeing it face to face. I don't know if I would do that as part of an intake, but I thought it was an interesting observation on his part. And it can even lead to loss of grip strength in the hand. That's pretty far down the line, hopefully. I think that's much more common in in carpal tunnel. Okay, so a few of the differences between thoracic outlet and carpal tunnel, and this is super important because we don't want to treat the wrong issue, right? Now, we can't diagnose, so I'm not suggesting that we attempt that, but the one interesting factor that I always think about when a client comes in with carpal tunnel is they may have been misdiagnosed. Now, again, I'm not a doctor. None of us are. We all know that. We're staying within our scope of practice, but we have the fortune of having more time with our clients than, say, a physical therapist or a physician. So, hey, if somebody presents with carpal tunnel, but you do some follow-up questions and you're asking them about which fingers are numb, or you're palpating and you see that their, scalenes are super tight, you don't have to just bill for your carpal tunnel treatment. You can do your thoracic outlet treatment too, because maybe it's that. So again, please, don't take me the wrong way. And I would never say to someone like, oh, your doctor was wrong, or it's not carpal tunnel, but I myself would do more investigation. And here's why. So doctors tend toward a carpal tunnel diagnosis. It's a really easy diagnosis to make. I think we all know a lot of doctors don't necessarily have or take enough time to truly do a thorough intake with their patients. They might hear, oh, I have numbness in my fingers. And they might literally say, great, carpal tunnel. And then they're out the door. They can refer them to PT, and they can also do surgery on them. So it's not a great surgery. I'm sure we've all had clients. I know I've had many who, when they have the surgery, their symptoms definitely come back. And part of that is because they're basically slicing open through the was it the flexor retinaculum? I should have restudied that anatomy. That was carpal tunnel. Is it the flexor something retinaculum there? Okay, he's the newest out of school, I think. They slice through that, and that's a really important section of your wrist. And then, of course, with any surgery, you're gonna have scar tissue. So you're creating scar tissue right here, which is exactly what's pinching down the carpal tunnel. So, but surgeons can bill for surgery. That's something that's in their wheelhouse. They don't like to think about something that they can't fix, right? So other than if you had that extra rib up here, thoracic outlet, there's not many things medically that a physician can do. They can't really inject for it. It's a little bit more complicated. And I even read somewhere in my new studies that some physicians don't even believe it exists. Very strange. So the reason why they don't believe it exists is because most of the signs and symptoms can be attributed to other causes and conditions. So I guess it's just not that popular, but I know I've had it and I think it's important enough that we should think about it. Anyway, so that's my little be fun diagnosing. Carpal tunnel, a few more differences. Carpal tunnel has numbness in the thumb and index finger, and Nick did show us how you can end up with more fingers numb, but usually the primary beginners are the thumb and index finger, whereas thoracic outlet, it's the last two, ring finger and pinky. So that's the key difference. You know, if somebody says, oh, I've got numbness in my fingers, I always ask which ones. Carpal tunnel tends to just be mostly hand numbness, mainly from the wrist down, and that's an overgeneralization. Again, you know, even carpal tunnel can work its way up when you start to compensate. But thoracic outlet, because it originates from the upper quadrant here, you're definitely going to have, it, you know, presents with more arm, shoulder, chest pain, and the numbness is the medial border of the forearm for thoracic outlet. Next step down, carpal tunnel is compressions of nerves only, because if you think about it, you don't really have a lot of vascularity down here. We'll see when we get to the anatomy next that thoracic outlet can be compression of the nerves and the vascular bundles. So the one interesting way you can test, if you choose to, between carpal tunnel and thoracic outlet is by sensing the temperature of the hand. If they have some vascular compression, the one hand that's affected will definitely be cooler to the touch because unfortunately they're not getting blood flow down there. And lastly, carpal tunnel usually doesn't present edema in the hand. Thoracic outlet tends to. That was what I was talking about when you can take a picture of the hands, or maybe if it's bad enough, you'd actually be able to see it. What I read was to be looking if the tendons are sticking out as much from one hand to the next. You know, yeah, that can be a good guide for swelling. Okay, so does anyone have any questions on signs and symptoms or the differences between carpal tunnel and thoracic outlet, or comments, of course?
I'm good.
No,
Okay.
that's great, Lindsay.
Thanks. Okay, awesome anatomy. Let's go there next. I love this diagram. Oh my goodness. I hope people can see it big enough. I don't know, people are on their phones, it might be really small. I think that this whole slideshow, just like Nick's class, will be available. Like we're all going to be given that as part of the follow-up, right? Okay, so let's talk about anatomy. Oh my gosh, this is just such a beautiful diagram because it's like, no wonder it's all compressed in here. To me, it's like a miracle that everyone doesn't have compression because it's so tight. Like, in what universe did our bodies create this whole important brachial plexus nerve bundle to have to, like, I don't know, just seether its way through all of these structures? But in defense of whatever created humans, I think that we were created before computers were invented, right? So like we didn't have forward postural issues when we were able to be upright more often and when we didn't stare at a screen. So anyway, the brachial plexus and the vascular bundle can be pinched by 3 different muscles. So up here, I have a different diagram that's better with the scalenes, but you see here, so we've got the anterior scalene muscle. I'm doing that with the cursor, hopefully you can see it. And then the medial scalene is right behind it, and then the posterior scalene, because you have 3 different scalene muscles. The brachial plexus comes right out between the front and the medial, and the brachial plexus originates from C5 through 8 and T1, so it's pretty low on the neck. And the scalenes are the most common muscle that pinches the brachial plexus and causes thoracic outlet syndrome. Interesting factoid about scalenes. You may remember this from school, but I think about the scalenes pinching and being tight often if you have somebody who's asthmatic, because they are an accessory breathing muscle. You know, we're supposed to breathe with our diaphragm, but if somebody's either anxious or asthmatic, they're doing this. So they're trying desperately to elevate the rib cage to get some sort of air into their lungs, even though that's not really how we're supposed to be breathing. But yeah, they can be really tight in aesthetics. Next, so the brachial plexus is already joined by the subclavian artery, and it doesn't really go through the subclavius here where my cursor is, and it's kind of a really weird muscle to massage. I actually don't focus on that much, either today or in practice. It can feel really weird to try to like massage underneath your rib there, but it is another possible cause of the pinch or something that's inflamed and causing the nerve to be pinched down. And then we kind of come down here and it's joined by the subclavian vein. And you see pec minor starting here at the coracoid process. It's one of our favorite muscles to work on, regardless of thoracic outlet or not, because it's a commonly stressed muscle. So it's got all these opportunities to get pinched down. And like I said, it's not just the nerves, it's also the vascular supply. Both of those can create the similar symptoms. I would say if it's a vascular pinch, that would be hopefully easier to alleviate, whereas a nerve pinch might have longer standing repercussions, because even once the nerve is released, it still might be annoyed. Whereas I think if an artery is released, hopefully the blood flow would just return back to normal. Some of the muscle testing involved like discerning whether or not it was a nerve pinch versus a vascular pinch. I personally don't think that we need to go into that much detail, because we're still gonna be massaging the same areas. So I don't know that I care what is pinching or causing the problem. I mean, I care between the different muscle groups, but I shouldn't say care. I don't know that we need to know or need to test whether it's a nerve pinch or a vascular pinch, because our massage techniques are probably gonna be pretty similar. Okay, this is just a specific diagram of the scalenes. It was a little bit more of a close-up. You can see again the anterior scalene, middle scalene, and posterior scalene. And then right here you got some nerve, that's the whole brachial plexus coming out. And what I like about this diagram is I think it is a really good demonstration of how, when you're massaging, think about this whole nerve supply coming out this lower section. You may not want to be doing a ton of direct pressure right onto that already irritated nerve bundle, but look at how much more muscle is above that. So you can work the belly of the muscle all the way like 3/4 of the way down. I'm not saying avoid this area. I usually treat the muscle completely, but it's just something to think about, you know, just knowing how low that brachial plexus exits the cervical area. Don't forget though, you can go below the brachial plexus and think about this attachment point, and we'll get to that when we talk about massage techniques, but it's a little hard to get to, but getting to that first rib attachment of the anterior scalene can be really effective. So that's why I like this diagram. And next, look at this one. It's so colorful. All right. I like this diagram. Wanted to share it because it shows the bigger picture. So here, you know, it doesn't really show the neck, but I love to think about all the surrounding areas. When pec minor is tight and yanked forward here, just look right here, this whole section of the scapula. So we've got subscapularis, got teres, we've got the lats. I think it's both teres minor and major. And I even think about serratus coming down to the lateral and forward portion of the rib cage, because if your pec minor is yanking your coracoid process forward, that's attached to your scapula. Guess what else is going to be involved? Everything that we just listed. So, you know, even if you have like perfect diagnosis, signs and symptoms of thoracic outlet, okay, let me just do the scalenes and the pec minor. No, you can't just do that, because you could release pec minor all night and all day, and these other areas are still going to have trigger points. They're still going to be tight because they've been going along with that posture for that many, months, years even. You could have somebody that is tight for 10 years before they finally have symptoms arise. So yeah, I just love this diagram because it shows a much more complete picture of the anatomy and how just how interconnected we are. And it doesn't even show the fascia. So, okay, one more little diagram. I guess, why do I like this one? You know, so that the previous one showed the front of the body and complications. This middle one here, you know, if you think about, okay, so here we got sternocleidomastoid, even though that's, again, not direct pinching of the brachial plexus, it's going to be involved. You can't ignore it. You can see the side view, it's so gigantic. This is really a huge cause of forward head posture. And the only reason why it's not indicated in the pinching the brachial plexus is because the brachial plexus doesn't go through it. But it could still be the cause of the head going forward. So you got to think about SCM. And then in response to SCM, going back to this middle diagram, you've got, you know, traps and levator scapula and all this amazing stuff in the back of the body that's like basically fighting. You know, I think about the front and back of the body as when they're in balance, they're neutral. Nothing has to fight or strain. When you're in a neutral place with gravity, it actually, you know, we're built to kind of be stacked and pain-free, but if you look here, the sternocleidomastoid and the specifically the levator scapula, this doesn't show it that well, but if you look at and think about a tent, so think about like two parts of a tent, you know, with the strings that are holding the tent up, right? And so your head's on top of that tent. If either side, either the levator scapula or the sternocleidomastoid is pulling the tent one way or the other, you got your head on top, and your head's not going to want to fall over. So your head is going to have to really like just compensate so much more for an imbalance between the front neck muscle and the back of the tent. So I don't know. I liked that analogy. It's not mine, but hopefully that image kind of is helpful to think about that triangle on the side of the neck. Okay, so that's my initial anatomy review. Any questions, comments, additions on that?
This is great.
Okay. Huh? And what did you say?
I was just saying it's great. I love the diagrams.
Oh, thanks. Yeah, it was really fun to find them, especially I think it's really cool to find free stuff on the internet. All right. But if you know what you're looking for, I actually got really picky at one point, and I was accidentally clicking on things that were Pinterest, and I don't have Pinterest. I'm not going to start a Pinterest account just to borrow an image. And I was like, why are all the good ones on Pinterest only? So anyway, okay, so this wasn't part of the course. Yes, it is. I added it in. Okay, so testing. Now, I was deep into, actually, yeah, you can't see it. You can't see me now. Let me just click off of this for 1 second. Sorry, because I want to just show you the book that I should have added it in, but can you guys see me now? So this book, I think we have it in the office. And do you guys remember this book from massage school? Mm-hmm. Anyone? Maybe? It's very thick. So it's clinical massage therapy, and it's really, really in depth. I remember when I was in massage school and we had that as a text, it seemed way, way, way too in depth for me. And even now, like the thoracic outlet section is really, really big and super, super specific. In fact, they differentiate between, like, they wouldn't even treat it as an entire thing. They have pages and pages just on like the one muscle possible pinch. But I just want to show you really quick. I was going to list all of these tests, but right here in the middle, this whole paragraph, that's like 8 different muscle tests. So they got Adson's test, Travell's variations, scalene cramp, scalene relief test, costocavicular, Eden's test, Wright's hyperabduction test, pectoralis minor length test, upper limb tension test, blah, 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 blah. So that's kind of a lot, right? And I just didn't really, I don't know. I don't know how people feel about doing testing as part of their intake. I think in massage school, we really did that a lot more frequently, but does it matter if it's pec minor versus scalenes pinching down the thoracic outlet? I don't know if it matters. I would probably treat both because, again, we're lucky enough to not be doing a 10-minute session on someone. So, and like me, this is probably a flaw of mine with my intake. I do a really thorough intake for a first-time client, but for repeat clients, I try to give them maximized table time versus, 25-minute intake where I'm doing all this like testing and stuff. And I feel like this is more appropriate for a physical therapist, but I still wanted to include 2 tests that I thought were pretty easy to do. So you can consider that. And maybe now that we have longer in between sessions, maybe it'll be something where we feel like we have more time to do a more thorough intake because we're not rushing to get the session started. So, okay, so AdSense test. This one is to, basically all the tests are to determine which muscle or source of the thoracic outlet syndrome. So this one is to test whether or not scalenes are the source of compression. So the way I gather this image is you're gonna feel the client's pulse, and then let's see. Then what? I guess you do what they're doing in the image. I think from a seated position or standing, you want to make sure that the client's scapula is sort of stabilized. You can see how it looks like he's stabilizing the back of his scapula from behind. You're gonna stand behind the client, and then you're feeling the pulse the whole time. So, and then the holding of the breath. I wish I knew what that was for. Maybe someone can help me on that, but I guess you're going to ask the client to hold their breath. And then if you sense or feel a disappearance or a decrease in the pulse, then that means that it's the scalenes. Maybe you're holding your breath because you're holding. Does anyone know why you would hold your breath for this test? Sorry.
When it extends your rib cage, it would push inwardly against that. So it would actively sort of challenge if there was inflammation under your, this is for under your,
the scalenes are for the neck, yeah.
Scalenes. Yeah. So why would you hold your breath? Yeah, I don't know. You have to use them if you take a deep breath, you definitely use them.
Yeah,
breath.
That's true. Yeah, maybe that's why. Maybe to engage it. Maybe you're taking a deep breath so that that's what engages the muscle in your chest. If it
I can really do it myself.
So anyway, that's one testing option. Huh?
Oh, go ahead. I couldn't really do it to myself.
Oh, well, you need someone to be holding your pulse behind you. It looks almost like the guy's getting arrested, but anyway. Okay, and then the next test, again, I only chose 2. This one is called the Wright's test, and you should probably remember this from massage school, from a seated, or you can have the client either sit on the table or in their client chair. So it's full on like hyperabduction, extension, external rotation. There's a lot of words there. And then all the time you're taking the pulse, and you should sense a reduction in, don't kill the person, only do it for a little while, but you would feel like the pulse getting more faint. And this one is to indicate the pec minor being the cause of the compression. And to me, that one makes a little bit more sense because I feel like that is really putting the pec minor on a stretch if you're doing that. That actually feels really good unless you're pinched. Okay, so again, you can kind of do your own thing. If you wanted to investigate more tests, I'm happy to share that book with anyone, or I can copy and paste that and add it in. It just seemed like a lot from our perspective, but sometimes more is better. Okay, so we've done all the way up to testing. Now we can do the approach, and then for massage techniques, I've got a couple videos and then want to add to those videos as well. Okay, so for the approach, how we're thinking about the client, how we're thinking about the body. I've already mentioned a lot of this when we were looking over the anatomy, but the surrounding muscles are super important, and postural habits aren't created by a singular muscle. So yeah, don't just treat the pec minor and the scalenes and the subclavius. Definitely check out all the other areas. The main cause of compression should receive the most attention, of course. And the one thing to be careful of is if the client is inflamed. In fact, from my personal history, when I finally did go to a chiropractor, wondering if it was, my vertebrae pinching things down, that was a part of the cause, but he wouldn't even touch me or adjust. He touched me to palpate, but he said I was so inflamed. And most of this was from self-massage and just like wrenching my neck around, stretching. I did like not more damage, but I did so much. I just thought, okay, like it hurts. Like I got to massage it out. I got to get rid of it. And I actually made it worse because again, if that nerve is inflamed or if you've got discs that are just blowing up, it's not good to add more energy to that area. So that was not the only time I've learned that lesson in massage career, but it was the first time I learned that. And I think it's important for me and all of us to remember that too when we're treating someone. And you can tell if it's inflamed, if they're really, red or swollen or, hot to the touch. You might want to go easy or not even focus on that inflamed area. Let's see, use some caution if what you're doing in the massage exacerbates the symptoms. So you have to have a fair amount of client interaction verbally. This is definitely not a relaxation session, although relaxation is of course important and you can maybe do some of that before and after the actual treatment of the area. But when you're doing that focus work, communication is really important. And I would tell my client that, really tell me if the numbness gets worse, tell me if it causes an increase in pain, but sometimes people can't even lie flat on the table without pain. So it's sort of like, what are you going to do? They're going to be uncomfortable no matter what. And you do want to help them, but I guess if it's getting worse in the session, maybe back off a little bit. But sometimes if you're dealing with that area, they're going to feel it and then it'll still feel better post session. So maybe like go easy to medium on your first session and then get their feedback. If it ends up causing the nerve to be more inflamed, well then obviously massage may not even be the answer for them. Sometimes you might need pillows or towel rolls. You can always consider side lying position. You might want to put like even a pillow underneath the shoulder because so say if they're used to being in that forward shoulder position, lying flat might be really uncomfortable for them. And not that we're trying to encourage that bad posture, but they have to try to be a little bit comfortable on the table. So like a light pillow underneath the back of the shoulder might be necessary. If they're really forward head posture, you might need a towel roll underneath their neck, or again, a pillow. I do that with a lot of clients, even when I'm not thinking about thoracic outlet syndrome, like some of the elderly clients, when they walk in and you can see they're really like this, they're not going to be comfortable flat on the tables, and I'm not going to correct their 80-year-old posture. So it's better for them to feel support. So use what we have in the office with pillows and towel rolls. Depending on how long their entire session is, I usually like to start with the area that's most presenting. And for this, you could spend at least 30 minutes just treating this issue. So make sure you start with it and leave enough time. These are lessons I think everyone already knows. So start to be basic. Okay, let's go now to a little video. All right, this is going to be a little, okay. I'm hoping I'll be able to do this right. Give me 1 second. I actually have 2 videos. Okay, I think I can do it. I believe in me. All right. Oh my gosh, is it going to work? Okay, yes. All right, this one is 5 minutes, but I did the Nick trick and I put it on 1.25 speed, so hopefully it'll be a little bit faster.
Right?
Yeah. It's funny, especially a massage video, they're trying to be so soothing and slow. So, I mean, God, they can make a 1-minute video into like a 10-minute video. So hopefully, yeah. Anyway, all right, I need to make this full screen. I'm sorry to be talking out loud while I do this. Oh my God. All right, is that full screen for people? Thumbs up if you can see.
Yes.
Okay, great. Here we go.
Your scalene muscles are comprised of 3 different muscles: the anterior scalene, the middle scalene, and the posterior scalene. These all originate from your transverse side processes of your C3 to C7, and they go down to your ribs and clavicle. These are important to work because they lead to a lot of neck pain. Trigger points can get embedded in these muscles, and those can lead to headaches. as well as there's a lot of nerve innervation that runs through these muscles. So any time that there is numbness or tingling down the arm into the hands, scalings could be a culprit. Looking into the massage here, I'm just working along the traps, the levator, and the posterior scaling towards the back. And one thing I want to focus on is just how slow I'm going. I'm not doing any rapid movements, but rather I'm just finding this tight area. The muscles here, they can all kind of become fused together. So I'm spending a lot of time just sinking into the muscles and separating out those individual tendons and fibers. And most of the time, I always work surrounding muscles before I target the individual muscles themselves. So this is just to release the outside muscles that might anchor it out of position. And so then we can go in and actually release trigger points and adhesions that we find.
Sorry, I just have to say, I love what he just said there about doing the surrounding muscles first. It's so, so, so important. And it'll also get the client to relax if you're doing something more generalized than just digging right into the area of concern.
On to the actual scalings. With the scalings, I like to start at the origin, the side of the neck, and then work my way down right underneath the clavicle.
And you see how he's doing a little bit of motion with the client's head. So you can't really see it because the video is not showing his other hand, but I really think his left hand is on her head, and he's doing just a gentle, it's like a rocking. So in my mind, I think he's doing a slighter version of pin and stretch. So it's a pretty cool technique.
Where I'm actually putting my fingers underneath it. And you'll see I'm rocking back and forth. A little hard to tell, but I'm actually moving her head as well.
Oh, he says
and that is just doing a very slight pin and stretch on the scalings, giving it a rocking action. So I'm getting pressure, and then I'm stretching them as well. And do work with caution here. There are a lot of nerves and arteries that you don't want to press too hard on, but staying on the muscle and occasionally checking in with your client, you'll be totally fine. Some pec work helps the scalings as well because they do attach to the first and second rib. Moving over to another angle, just to show you how I work the origin of the scalings. My first clip was primarily down at the clavicle and rib attachments, but this shows you really well how I'm going slow and starting at the transverse portions of the neck and then working down under the clavicle like you just saw. Walking back across the clavicle, and then you'll see we go back up the traps to the origin again, and then we're working down the scalings and SCM, and all of that collectively is known as the scaling triangle. And finally, I do like to throw in some vibration, especially on the origin part, where the scalings are very stuck together. This is more just an addition to separating out the fibers, releasing the tension, releasing trigger points. And then, of course, always follow through the muscle all the way until it attaches and keep going. You never want to stop massaging a muscle halfway through because the stroke feels very incomplete and it doesn't feel that great. And I'll trace the scaling triangle a few more times. This time, I'm going to go back in with my thumb just to get a very specific deeper tissue stroke. I always say never to use your thumbs too much, but only in moderation, and only when you're doing lighter, more specific work like this, in order to save our thumbs. Then, as the massage is finished, you can go in to work the suboccipitals or other parts of the neck, or move on with the rest of the body. Thank you all for watching. I hope you enjoyed the video. Give it a like if you did, and
okay, let me get back to, oh boy, this was the hard part. How do I get back to you guys? Maybe I will, sorry, 1 second. Okay, so I want to add to that before I do the next video. Let's see, so massage techniques, the next is for pec minor. So that was an awesome, I would say, beginning of a neck routine. Obviously, it was just a 5-minute video. And, you know, it looked like he was starting with effleurage, warming the tissue. You can
alert from keyboard batteries very low.
Sorry, my keyboard batteries are very low. you could even start the massage in general with hot packs. Even though I talk about ice more than I do heat, it's good to put a few minutes of heat on them before you get things going. He talked a little bit about doing the surrounding areas, but I think going further than just massaging the surrounding areas, you want to even address the trigger points in the surrounding areas. So that would be upper traps, lats, teres, subscap, pec major, and serratus anterior. And now for the specific part of massaging the scalenes, I just want to add a few things to what he talked about. And, you know, we could do a little bit of, I don't know, maybe massaging yourself while we're talking about this. So there's a pincer technique, or I think they called it like the money symbol, right? Like you're like rubbing money together on the SCM. It's a little hard when you're sitting or standing, so feel free to lay down. You know, you don't always have to show your faces, right? During the video. It's easier to massage the neck. It's relaxed. You can even do a little bit of oppositional stuff with SCM while you're pinching it. Just kind of zooms those little fibers open. I actually didn't really even think about skin rolling, but skin roll, I don't know how we can do this on our own necks. Let me see. Skin rolling, I guess little pinches. I would do it laterally, the skin rolling, and that's a really hard angle to get to. But skin rolling is really cool and a forgotten technique, I think. I actually use it a lot on people's forearms. Yeah, feel free to lay down if you want. And once that area is all warmed up, I actually do, for me, when I massage the scalenes, I do a ton of cross fiber friction. And I mean, I do get in there. Like if somebody needs their scalenes worked on, effleurage is not going to be enough. You know, of course, working within a client's pain tolerance, but like, so I would be right near to the transverse processes and in between them. And like my neck is super, super tight. So this is like bands of rubber bands right now. So it's like strumming a guitar. But you don't want to just strum over it. You want to really pin the muscle and friction it. And that's what helps it to loosen up. So cross fiber friction, the entire scalenes. You can also do pressure points. We already talked about it. You can get them to lift up their shoulder a little bit or do it with yourself. And then you can insert your fingers onto that top rib attachment and you can friction back and forth in there. Yeah, I saw Anne moving her hand. That's really good. You can move. Ooh, that's good. Yeah, you can kind of get in there a little bit better. While you're on that lower attachment, he was doing like a easy version of this, but you can really pin that on the rib and then be pinning and stretching in a slightly more intense way. I think he was doing more of a rocking, but you can do this on your own. You guys feel that? I mean, again, if you don't have a neck issue, it might feel silly or it might feel unnecessary. But I think a lot of people are tight in the neck, even if they don't have this issue. Okay, so let's see. Oh, this is a great next stretching. There's a stretch technique where you're holding the client's head. So say I'm at the end of the massage table, you get them to come up beyond the end of the table. So you're holding their head in space. Now, you gotta be able to hold their head with one hand. And then you would be touching on the front, basically either where the SCM is attached, or you can even go into the scalenes, and then you're going to be slowly dropping their head. You can even do this on your own at the end of your massage table. It's not much nicer when someone holds your head, but it's a really cool pin and stretch technique. And instead of just backward, I actually like to go a little diagonal. So yeah, without hanging your head, you could even do this like on your own. You could even just pull the fascia. It doesn't have to be like digging and tugging. Is that making any sense to people? Okay, let's see. So stretch technique, pin and stretch. We already did the pin and stretch. And yeah, don't forget about the back of the neck. So while we're here, we can do a little petrissage. Ooh, petrissage on the back of the neck. Who misses massage? I do. Oh boy, it feels so good. And because if they have forward head posture or, you know, any sort of like, you know, restrictions, they're probably going to have some trigger points into the posterior of your neck. And I love to finish with the CV4 hold. So you're basically, you know, you're underneath their head. You really want to get into the suboccipital, you know, some they actually perform it, honestly. I've had people that stop, not even on the sorry, you probably can hear me, probably not even on the suboccipital bone. I should have had an anatomy of that, but you really want to get to that attachment, which is higher than some people apparently stop. So you're curling your fingers under. You can either do just the finger curl, or the true CB4 hold is with your fingers at 90 degrees. And that can be a little intense on your fingers. So, you know, if that's too much, don't do the full on one. Start with just a finger curl and just hold, and you can also traction that way. And no matter what, the neck wants space. So that's a really cool thing to give when you're tractioning their head at the end. And because they're already probably going to have a lot of like lymphatic crap held in the area, and you've just done more work that can be kind of intense to that area, it's really nice to end with lymphatic drainage. Frankie's the expert on this, but I know less. I think I remember that there's like a really interesting way to kind of, it's like an L. You basically, you start downward and then pull outward. So it's an L to kind of get the flow from the neck, and then the like dump station or whatever would be toward the lymphatic uptake in your axillary area. And Frankie, do you have it? Like, what would you do for lymphatic?
Everything coming down from the neck kind of empties out into the middle here.
Right.
That's where your major drain is. You want to get everything kind of coming down right here into that notch. And then everything below is going to either be coming into that notch or going out to the axillary. There's a drain right in your armpit. So then you drain everything below the clavicles to the armpit.
Okay, and like it's really light, right? You just want light.
Very light. You can go a little bit deeper right here. At the top of the sternum there, you go a little bit deeper because you're trying to get it down below the collarbone and the top of the sternum, because the drain is just below that bone.
Okay.
So you want to go, as you get there, you drain down just a little bit deeper. And then again, with everything else, very, very light. Think of like the weight of a nickel. That's about how deep you're going into your skin. And then you drain it towards the armpit. And again, you start kind of going a little bit deeper in the armpit.
Thank you. Our resident expert for lymphatic. Okay, I know we're getting close to an hour, but there's a short video I want to share, and then I can speed up the finish up stuff. So I appreciate your tolerance, patience, and attending at all. Okay, we're gonna move on to pec minor. That was very brief. I really wanted to, when me and Nick met, I made a video with him for foam rolling, and I was like, I wish that we could do hands-on massage, because when I was looking for videos, I mean, the videos are fine. I actually like them both that I chose, but you know, I searched for an hour and a half to even find these, and I would love to do a video of kind of much more specific techniques, because I feel like these are pretty general. But when we get to work again, I'm happy to show anyone lots of tips and tricks for working with the neck, because I do a lot of it. So, alrighty. Pec minor with Whitney Lowe. Woohoo!
The pectoralis minor is important to treat in certain neck pathologies. The pectoralis minor can be involved in various postural distortions and variations of thoracic outlet syndrome, where nerves or vascular structures are pinned by the muscle against the upper rib cage. Because it's deep to the pectoralis major, it can be challenging to treat. This active pin and stretch technique reduces tension in the pectoralis minor without putting excessive pressure in this area and further compromising nerves that may be compressed. Have your client reach down towards the knee, and this puts the pectoralis minor in a shortened position. Take your fingertips and apply pressure directly on the pectoralis minor muscle. Make sure that your pressure does not aggravate any of the existing neurological symptoms. While maintaining pressure, instruct the client to lift their shoulder up towards the ear as if hiking the shoulder. In so doing, we pin and stretch the pectoralis minor, applying a short static compression or a short stripping technique on the muscle during the technique. Once again, if you will reach down towards your knee, pin the tissues of the pectoralis minor in this position, and now lift the shoulder up towards this ear, and a short stripping technique on that pectoralis minor. This is a very effective way to reduce tension in the pectoralis minor muscle Just make sure that none of your pressure aggravates any of the existing neurological symptoms.
Short and sweet. I like that technique a lot. And actually, I haven't even used that one. I'm not sure why. So I learned something new by creating the class. Okay, I want to add a little bit to pec minor. Of course, you're already having warmed up the area. Oh, what is that? Do you hear music? Oh, it's still on the other one. Hang on. What's happening? I've got a YouTube thing still playing. I thought I pressed play. Oh my gosh. Could you guys hear that? That was really funny.
Yeah.
Okay. Okay. So yeah, you're already going to have the area warmed up, pec major. And I also think about the biceps. Biceps, I believe, brachii, it inserts into the coracoid process, and the anterior deltoid area, because it's involved. Pec minor can be massaged either through the pec major or by accessing it laterally by going under the pec major. It's got to be sensitive. You'll know it when you're pec minor because the client might be hopping off the table. And you can work the attachments and the belly of the muscle. If there's any question about whether or not you're on pec minor, I think that there's a way where you have them, it's not just push forward because that's pec major, but I think you have them actually rotate their scapula forward, then you'll know you're on it. Pin and stretch technique, similar to what they did. I like that pin and stretch in the video. You can also have the client come so far on the side of the table that actually their entire scapula is off of the table. So not just enough to move your arm off, but enough that the scapula can be depressed backward. And basically, like, you would have their arm up, you're holding onto their arm, you're not pinching, but pressing on the pec minor, and then going back like this. And you can probably do this sitting, but it feels even better when you're passive, when the client is passive and you're just, does that make sense? I'm sorry, I'm not describing it that well because I'm not on the table and I don't have a body, but you're basically pinning and stretching by allowing the client's arm to come down below the height of the table. Okay, myofascial release is also great. You can kind of be in the pecs. You could do a cross hand technique with both pecs. Pulling myofascially, or you can just do the one side, kind of just finding where the fascial restriction is, holding that for at least 30 seconds until you feel a change. Don't forget side lying position. This might be more comfortable for the client, and also it allows different access for definitely pec minor, but also for the neck. And Nick has taught a whole bunch of awesome side lying techniques for both those areas. Okay, would anyone like to add anything to techniques on either pec minor or scalenes or anything we've talked about? Any like awesome tricks? Frankie, thank you so much for the lymphatic stuff.
I've been using a lot of this, and you can do this with self-help too, but you can use your opposite arm to get your scalenes.
Yes.
And you can just kind of let your arm hang. And it does nice work, you know?
That is so good. What do you call that? We got to come up with a name for that.
Yeah, yeah. But and you can really,
yeah. And it's almost, I think the way that you described it, Nick, it's a little easier on the therapist body doing it that way too.
Yeah, yeah. This is the Steve.
And it's a little less invasive too, because you're almost like pulling the muscle versus like digging in directly.
I tell you, I'm quite confident that I or my doctor misdiagnosed because we couldn't meet, you know, and but I strongly believe that I've got that. And I'll tell you, the thing that really got it was I carried my kids up a mountain, and we have these packs that are like, we got them used, and, you know, we didn't know if we'd be doing a lot of hiking or if the kids would tolerate it. So we could probably get much better backpacks. My shoulders were killing me. And it said something about carrying a heavy load. And those kids, they're a load, man. And they were like, it put so much pressure on my shoulder girdle. And at the same time, I was doing some vibration stuff. So I think I did a double whammy. But
yeah.
the feelings, even just doing this work, I have such warmth and sensation in my hand. I can't even believe it. And it's from the scalene stuff. I
So good.
think I was really like trying to power forward when I had that thing on, and I think it really jammed up my scalene. So
Yeah.
I think you're really onto something here.
Thank you.
That idea of misdiagnosis between carpal tunnel and thoracic, or likely a combination of the two sometimes. I think it very well makes sense that more than one thing could be happening when danger rears its ugly heads for elbows and wrists and things and shoulders.
Yeah, well, I'm glad that you're getting some blood flow, and hopefully, you know, no more Sherpa, but that's unlikely, right?
It is unlikely. I got to get it better. They like it. They deal with it. So I've got to get a backpack that's maybe more suitable for it.
Yeah. Okay, well, just one last slide, and then we can close out with any questions or anything else anyone wants to add. But home care is really important, right? So we can massage. So we're blue in the face. We can do. I always say the massage is 1 hour out of one day, and there's a whole lot of hours that people go back to their regular walking lives and daily lives and activities that can do the massage, or just that's why they came to you in the first place. So they have to do home care. It's interesting to try and get clients to comply to home care, but if you explain it in that way, or explain like, hey, this is a partnership. I'm doing this with you now in the session, and in order to maintain your results, this is what you have to do. I mean, I'm very clear about it. I'm not like, you know, grr, hopefully. Maybe a couple clients here and there have thought of me that way, but I just think of it like, you know, if the dentist tells you to go brush your teeth twice a day, that's proper home care. If you go to a physical therapist, they're going to give a packet of exercises to do. So it's totally within our scope of practice to suggest some of these things, and it's important for their results. So I feel like it benefits them. So I'm a big fan of ice. I think it's way more therapeutic than heat. It, you know, vasoconstricts and then vasodilates, so you're going to get a ton of nutrition to the area and nutrient exchange and taking the crap out of the way. And if there's inflammation, ice is key. So I would recommend ice here to the scalenes, or to me, sometimes it feels really good to even get like right where it goes through underneath the clavicle here. And I've even been known to shove an ice pack underneath my sports bra, because that keeps it right in front of the coracoid process, which is another section that the whole nerve bundle is going through. But side of the neck is a great place for it. I think I do it under the sports bra, because then I can still do other things. Like, heaven forbid, I just sit there with ice for 5 minutes. But I actually think 10 minutes of ice is great, at least twice a day. I personally try to do my ice when my symptoms are just starting to come up. Don't wait until it's a full-on flare. Why don't we take care of ourselves when the body is just whispering little hints, rather than waiting until it screams? So you can advise that as well. We just went through a whole bunch of stretches for the neck, pec minor. You know, we were doing more like self-massage. You all know your stretches, you know, whatever, lateral neck stretch, pec minor, doorway stuff. I think everyone here knows those stretches already. A cool PT technique is the neck retraction exercise. I think it's within our scope of practice to recommend this. It's not like a full weightlifting exercise, but basically you're going to give yourself a double chin. So neck retraction, we all have this like forward head. You basically pull your chin in. And I also like to think about my head going up. So you don't want to just be like, extremely back. It's a slight in and up, and it's to correct this forward head posture. So you can see how like this, if you do a neck retraction, it's really lovely. So you can look that up online or just demonstrate it. And what I've seen is actually even doing 10 repetitions of that at least once or twice a day. But I don't like to force that. You don't want it to be extreme. It's not like you don't want to build neck muscle. It's just a postural correction exercise. And another one is scapular retraction. With this one, it's not just bringing your elbows back. You're not just focusing on the elbows. You really want to think about between the scapula, like holding the scapula as if you're trying to pinch a pencil between them. So some people, when they do that, again, they're just thinking about their arms pulling back. You can even do this with them in the office before they leave. Like, put your hand between the scapula and say, engage here. This is where you want the scapula to be brought back. And then, yeah, you can, observe their posture. You would have already done that in your intake, and give them some recommendations for how to think about their alignment. You want the hip, shoulder, and ear all to be in alignment when they're standing. Sometimes I have people stand against a wall and they're shocked that their head is this far forward. So I say, stand against a wall. Feel what that feels like. I like to think about a balloon coming up from my head. Again, so I'm not like lifting my head up extremely, but to lift your head, just do it. Like I even pull on my little hair a little bit. It feels great. Like the weight of the world is off your shoulders when your head is just lifted by helium. And then of course, if you think that, not that we can diagnose them as needing a chiropractor, but especially for PT, I don't hesitate at all to say, like, you probably could use some PT, because if you think about it, their insurance will cover it. They can probably go 3 times a week. There's some great local PT places that do hands-on work. So, they're going to still keep coming back to us because they love us and they need our work. But if they can get care that is more frequent and also technically more, specified, that's important. So don't forget to refer when needed. Okay, that's all I have for my slideshow. I had other videos if I needed to fill time, but I know Nick was considering adding one of the videos, but I guess we didn't need it. So thanks for listening, everyone.
I can put it on now. Let's see.
It doesn't work.
Do you want to press stop share on my end, maybe?
Let's see.
Or just press stop share.
Okay. Oh, here it is. I think this is it.
Hi, I'm Harvey, one of the senior massage therapists at Bodywork Professionals. Hi, I'm Lindsay Harvey, one of the senior massage therapists at Bodywork Professionals here in upstate New York. Right now, I'm going to show you a brief foam rolling routine to adjust the arm and pecs. Here we go. So what I do is face the foam roller, just going to guide my arm palm up to hit the back of the upper arm, also known as the triceps. We can roll back and forth, and we can shimmy. It's really fun. Then to hit the biceps, you're going to rotate your arm so that you're hitting the front of the upper arm. I'm almost turning my palm the complete opposite way. The biceps will really connect well to getting the pectoralis major. I'm just going to lean in like this, getting the front of the chest as it leads into the axillary or armpit area. And you can actually even lay your whole body on this and just breathe and kind of sink in. That feels really good. After the pecs, we'll go back to the rear side of your axillary area, and that'll hit the lats and the rib cage. So I'm going to be completely on my side, thinking about the ribs. This can be really sensitive, so if it hurts, just go easy. You can wrap your foam roller in a towel, or just lift your body up a little bit more. And you can go all the way down the side of the ribs here. Ooh, that feels good. And that is the routine for the upper arm, pecs, and lats.
So we'll have a series of those with different body parts as part of our self-care page. And we've got a social guy that does a pretty good job of putting that stuff up occasionally, once a month or so. And clients like it, and it is good to be able to point to something like, what should I do after a session? Well, here's a great thing. It's a foam rolling routine for, it looks like you've got some thoracic outlet going on, and here's a great thing on our website to kind of show you what to do. And it's cool to be able to see people that share that stuff. And, it's funny, I think clients not only expect us, they really want to know what to do after a massage, right? And sometimes it's hard to answer that. And so it's great to have some visual representation. Well, thank you, Lindsay. You did great.
Thanks. I was nervous all day.
No, that was really good.
You did a great job.
Thanks.
for those of us who have joined a little bit later, John is here. He is going to be a new NIS unitherapist, and he's going to get started when we get things rolling again.
Yep, I'm really excited too. And it's nice to see some familiar faces. I'm looking forward to meeting the rest of you.
Yeah. Thanks for joining us today. And Anne, you've got the helm with the wood element for the next class. Is that right?
Yeah, if folks are interested, I kind of went back through my CNW books and got intrigued with shiatsu and the wood element and spring and all of that. So I put together a presentation, and Nick is reviewing some of it. I'll have more of it on Monday, and we'll see how it goes. Yeah.
It's wonderful, and I think it'll be really fun to change hats like that. And we've done some pretty sort of technical things, and we've got to use our whole range of thinking. And so I'm really looking forward to it. And Frankie, I think I would like you to do the lymphatic drainage one. And this will be like lymphatic drainage 101. And we'll be heavy in anatomy and just like, where are the big pockets, and sort of how do we do that? So it'll just be a real basic kind of overview, sort of gloss over things. And I think that'd be really great. I've actually never taken a lymphatic drainage class before. So we can figure out timing. And Amy's going to do a Thai massage. I think she's even got like a Thai massage video. Is that right?
I recently did a class for advanced teacher trainers, yoga teacher trainers. So I have a recorded Zoom of that. So I can probably pull clips from that, or I can just do a brand new one, because I have a built-in model that I'm quarantining with, so I can do that too. I have an office down the street, and so.
Sounds good. Cool. And for everybody else, it is your assignments. You get paid $50 to do it, and you're awarded 3 credit hours from the state because you taught a class. So it takes a little while to do, and it causes a lot of stress, but I think it's really satisfying when it's all done. It's nice to have it done and know that, oh, I know more about that, and I shared it with my peers. So great, guys. So today, Friday at 2, looks like it's a good time for a lot of people. Robin said it's not a good time for her, but we've tried it every day at different times, and I'm thinking Fridays. I think Fridays at 2, we can kind of look forward to meeting then like this and having our classes. If that obviously works for this group. The group that isn't here really can't speak for them, but let's plan on next Friday, and that'll be Anne's class.
All right. Happy Friday, everyone.
Yeah, it was good to see everyone.
Thank you, everyone. Have a great weekend. Great job, Lindsay.
It was good to see full Sarah and Seth